I'm really excited for this panel. So we've all read the headlines from the census data that sometime between 2040 and 2050, people of color will be the majority in the United States of America. And part of the mythology of America is that we're a melting pot, but I think a lot of people have started to rethink that analogy, and it should be more like a stew or a bouillabaisse, where each individual flavor makes up a bigger thing rather than us all being treated the same way, right? But we haven't really seen that in healthcare, and that's what our panel is about today. So, Abner, I want you to describe for our audience what ConsejoSano is.
Sure. So we are a venture-backed early-stage startup company. We focus on patient navigation and patient engagement, really trying to reach groups of people who the health system does a very difficult job of reaching out to. As you said, America has changed. That's the reality we're dealing with. America has changed. It's now multicultural, and it's becoming more so. Soon we'll be according to the census, majority-minority country by 2050. California, where my company is located, is a majority-minority state even today. So the country has changed, but healthcare just has not. It hasn't kept up. And so, in effect, what we are doing today is we're saying to people, you need to change who you are to get healthcare. And what we're finding is that that just doesn't work. It'd be great if it did, but it doesn't. And so we've got to find a way to connect with people where they are, starting with culture and layering on language, and then using new technologies like big data and analytics to know people at a deeper level, and then to deliver that in a way that they want to receive communications, which we're finding is text messaging. So what we're focused on is doing exactly that, connecting with people who they are, seeing them as unique individuals, starting with culture, and then engaging them and navigating them so that they can access healthcare. It's not enough to say to people, healthcare is here. It doesn't meet your needs. You don't understand it. You don't connect with it. That's not enough. We've got to reach out to people and connect with them where they are, and that's what ConsejoSano is all about. It means healthy advice in Spanish. We started with a focus on Spanish speakers, but now we work with all groups, including English speakers.
This started for you when you were working in Mexico, right? You started to understand that there was this disconnect. Tell us a little bit more about how that was the beginning point of what ConsejoSano means.
Sure. I was doing work in Mexico, running, at that time, a nonprofit focused on HIV, and then we started to work with companies to deal with stigma in the workplace, and the companies said to me, help us with other issues like chronic disease. And so as we started to work with chronic disease in Mexico, what we found is that there were certain technologies like telemedicine, which has been mentioned here, growing faster in Mexico than in the US. Because of legacy issues around state practice of medicine and other issues, telemedicine has taken off slowly in the US, starting to speed up. In Mexico, it was going much faster, and what I saw was that telemedicine in Mexico was targeted at the growing middle class. These were people who were a little higher income, not rich enough to come to the US and get care, but they didn't want to depend on the government care in Mexico. They were looking for new solutions that were confidential, convenient, high quality, and so telemedicine was focused on that growing middle class. And so what I wanted to do was to take that concept and that way of thinking and bring it to the US and then serve low-income people. Most of our work is with Medicaid populations, and my feeling was that we shouldn't have a situation where the best solutions, the new solutions that really drive better outcomes and are more convenient, are reserved for high-income people. We ought to be able to figure out how to target some of those solutions to low-income people. That's what ConsejoSano is all about. And it's an interesting example of seeing something working in another country, targeted at the growing middle class there, and then bringing that concept and that way of thinking that we don't have to settle for full quality just because people are low-income. We can provide high-quality, convenient services, even to people, even if they're low income, if we focus on it and we use technology to deliver it.
Yeah, your logo looks like it's an iPhone with a stethoscope attached to it. So just quickly, tell us practically how it works.
So our clients are typically health plans or providers doing managed Medicaid. They come to us frequently because their HEDIS scores, which is sort of the clinical quality measure, are low, and they're having trouble connecting with significant and growing parts of their member and patient populations. So we integrate with their electronic health record system. We download people who have gaps in care. An example is moms who need to bring their babies in for vaccinations, immunizations. They don't trust the system. They don't understand it. So we reach out to them in a culturally, linguistically appropriate way, typically through text messaging. We build that relationship. We explain to that young mom or that dad why they need to bring the baby in. We tell them where to go. We make the appointment for them. We do the appointment reminder. These are low-income people. They have tough lives. Being poor is not fun. Don't let anybody fool you. And so they struggle and trying to balance, do I stay home from work and take my kid to get vaccinated? But that means I don't make enough money to keep a roof over our head or put food on the table. So if you're a mom and you know the right thing to do is to get your kid vaccinated, but you want to have food on the table and you want a place to live, it's a tough choice. And what we've got to do is figure out how to connect with people, build trust with them, and then figure out a way to help them make that connection, to lower those barriers, and that's what we're doing.
Kyung Hee, I want to bring you in. You were sharing with me backstage the part of New Jersey where your hospital is really is seeing what we described in that census data now. Can you tell us a little bit about your population?
Oh, our Asian population is growing tremendously in New Jersey. So when you look at the census report between 2000 and 2010, Asian Americans in New Jersey grew 53%. And now 10% of them are Asian Americans. And Bergen County, where Holy Name Medical Center, my hospital is, it's 15% of them are Asian Americans. One particular town nearby our hospital called Palisade Park, 51% of residents are Korean Americans. So when you have this many Asians coming into New Jersey as their destination because of a good school system, good living condition, it's growing pretty fast, and our hospital, Holy Name Medical Center, decided to establish a more culturally sensitive care program. And that's the start of a Korean medical program 10 years ago. And along the way, we added a Filipino medical program, Chinese, Indian, Asian Indian program, and Japanese. Now we call ourselves as Asian Health Services. It's all about delivering culturally competent care in partnership with our physicians. We have 280 Asian American doctors who are working with us, as well as in partnership with community leaders, even philanthropic partners. They donate to support our community outreach activities. So both at individual level, as well as community level, population health management level, we are so-called boots on the ground. We understand Asians. We understand what they want, what they need. It's not so much forcing them for them to come and understand the healthcare system, but we go out in the community setting and deliver preventive care screenings and bring our doctors. They love to see doctors in the community setting. So that's where we go, where our population is located.
I want to follow up with you on some of the culturally competent issues in this. They're fascinating. For example, a nurse might write on a chart in red ink.
Right.
What would that mean to an Asian
Korean
patient?
It's absolute no-no. Because in olden days in Korea, family register office, when you pass away, your name changes from black to red. So think about it. When you go to hospital, nurse picks out red ink and write down your name, and Korean people will be scared. Mm-hmm. And also room number 4 is stigma. And room number 4, when you say in Korean, Chinese, Japanese, it means death. So we try to avoid room number 4, inpatient rooms for Asian people. And also even serving icy cold water is not good, because Asians are trained to drink warm water when you are sick. So you certainly don't want to shock your body with icy cold water. It's funny that I was delivering my girl in a hospital. My roommate, right after delivering baby, she was taking a cold shower, drinking champagne, and my mom was so scared. And she goes, "Don't do that."
Walter, I want to bring you into this conversation.
Sure.
You've been at Carney for 3 years now.
That's correct.
What did you find when you got there with relation to this issue and the population at Carney that you thought we need to change and we need to adjust?
What I found at Carney was that, it was a hospital at a time when it was built in the 50s. The population was primarily Irish and primarily Catholic. But the neighborhood had changed dramatically. It is the most diverse neighborhood in Boston today. with over 50% of the population in Dorchester coming from multicultural background. Yet the hospital hadn't changed. And that meant that if we were going to serve our community, and if we had the fundamental belief that all people deserve access to health care, regardless of their ethnicity, their health shouldn't depend upon their wealth, that all should have access regardless of the language that they spoke, we needed to fundamentally change how we operated the hospital. And we did that in a variety of ways. The board changed dramatically to reflect the communities that we serve. We have, I believe, the most diverse board of any hospital in the city of Boston. We also changed our perception in the community, and that meant a lot of work. I greet every employee who comes into our hospital at orientation, and I explain to them that if you're in a blue-collar working family and you walk into our doors because you have a healthcare complication, your whole world collapses. You may be worried about being able to make that next paycheck for your family. One loss of one paycheck is a disaster for a family that's living from check to check. That meant that we must be culturally accepting. We must understand the shoes that they walk in, and that meant we provide translators. We hire people who come from the neighborhoods who our patients come from, so they understand their culture, they understand their background, and we are as welcoming as we can be to our community. That has changed the makeup of the hospital. We have, I think, brought about a significant change in that people feel accepted coming into Carney Hospital, where they may have not have felt that way previously.
What does having a diverse board mean? How does that change the hospital?
I tell our board that not only are they to look at the productivity of our staff and the financials of our hospital, but they are also the ambassadors of our hospital. And because they are in the community, they are reverends in the community, they are community activists, they run social agencies, they run businesses in our community, they work on Main Street. When I have a member, a patient in our hospital who has had a complication, it gets to one of our board members and they call me up and I encourage them to do that. Mm-hmm. And that means that we have a connection to the community, that perhaps we're not serving the appropriate food for that culture. As you've mentioned, so very important to people who come into your hospital. We changed our menu we have an Asian, we have a large Asian community, so we have an Asian portion of our menu. We have changed fundamentally how we see our patients. And that has brought about change. So as our board members, people have access now. They have someone that they can talk to, so that instead of feeling like I have to deal with this, even though they don't know my culture, or they don't understand my religion, or they don't understand the complications that I'm dealing with in my family, we have ambassadors who can say, Walter, this patient called me because of blank. And I get on that right away with our staff to make our hospital feel as comfortable as possible to everyone who lives in our community.
This is for anyone who wants to take this question. How has the current administration's stance on immigration changed the way you work or affected the way you work?
So at Holy Name Medical Center, it really takes the system-wide commitment to deliver culturally competent care from board of directors, CEO down. So it is ingrained into everything what we do internally within the hospital. So whether Asian people are hitting ER in the middle of the night or inpatient unit, outpatient unit, people know what to do in terms of navigating and providing the culturally sensitive approaches. That's important. So system-wide commitment to me, is one of the success factors.
I'm glad you answered that. I think you knew I was talking about the Trump administration towards immigration policy, especially because you deal with the Latinx community.
Sure. I think in brief, it has created fear. And it's challenging enough for people for whom English isn't their first language, and it's a new culture to try to interact with the health system. And you add to that they're poor and low income. That adds its own barriers and difficulties. And then when you add to that if you go to where you're supposed to go, the safety net, which is typically a federally qualified health center, FQHC, this is part of the safety net. Well, think about it. If it's hard to find a Hispanic family that doesn't have someone they love who's undocumented. And so going to a federally qualified health center, which is where you're supposed to go, in an environment where immigration agents, ICE, is rating all sorts of things, and the threats are even greater than the actual actions now. It makes people not sure about what is coming. They're talking about now using the census as a way to go after people. So I think it has created fear. It's made it more difficult.
Have you had to adapt?
No question.
As a result?
And
how?
Building a trusted relationship with our users, we call them our consumers, their patients, but we try to treat them as consumers, communicating with them, first listening, trying to hear the fear, because people aren't, when they're afraid, and what they're afraid of is something like having a family member ripped away because they took the kid to get immunized. Mm-hmm. That a husband and wife go to the clinic with the kid and they leave with just the mother and the kid because the father's taken away. That fear, trying to first hear it, because people are afraid to even tell you that they're afraid. Why are they afraid? Because they got an undocumented person. So listening is key, and then building trust, using language and an approach that's designed to build trust. And you don't build trust quickly. It's not easily done. In the current environment, it's harder than it's ever been. But I think that because of the clients we have, the providers and the plans, they have good reputations. We're able to use that, and we're able to take the time to communicate with people. So our service, we text message, but if we can't get a result using text messages, we actually do outbound live calls with agents who are from the community, who understand the culture, and we try to build that relationship. But it's all about trust, and what's happening now in the current environment is just disastrous of that relationship.
Walter, what would you like to see changed in medical and nursing schools with regard to this issue?
I would like to see, and to touch on actually what you were just, and this dovetails nicely into that, that the immigration policy has impacted Carney in two ways. One is the patient access that we talk about, and the fear to be able to come in for health care, that could result in something devastating to your family. The other part of that is Carney is an academic hospital. It's a teaching hospital.
With Tufts, right?
With Tufts University. Many of our docs who are coming in for the residency come from all over the world. Mm-hmm. So if they are afraid to go home because they may not be able to come back into the country even though they are here legally, that impacts us as well, and it impacts our health care and our ability to deliver to our patients. And so I think that's one of the adverse impacts that we haven't looked at, and I think that it is discouraging those who are in med schools in foreign countries from coming here in the future. And that's going to have a devastating impact, especially when we see that we are losing primary and geriatric care physicians. This is not the step that we want to take as a nation. I think that we are going to have to focus in our universities on bringing diversity into our schools. We do know that people feel comfortable with someone who understands their culture and understands their background to take care of them. And if we are going to have to encourage that more and more, especially with the immigration problems that we are now experiencing.
Do you think a second language should have to be required?
I think it would be helpful.
Required?
I don't know if I could go that far, but I think it would be helpful and encouraged for academic institutions to look at that as a qualification that makes that applicant very unique and worthy of extra consideration.
I'm going to open it up to the floor in just a moment. When you were first starting this program, Kyung Hee, and you were recruiting doctors to come, Asian doctors specifically, what was your pitch?
My
was your way you got 'em in?
was join us to serve the community. When you look at doctors, medical doctors became a doctor because they have a right heart to serve patients, to serve people. So, and same with me, and I wanted to do something good for my community members, and same for my hospital. So our missions are all aligned. So when I ask doctors to join to carry out this community service mission, and many of them have signed up, and it's not unusual for us to see 80, 90 doctors coming together and volunteering all day on Saturday on a health fair, where 2,000 people come to do free health screening. So that's one example of how doctors are jumping in and partnering with us. So that was the way how I was pitching.
Yeah, we should also I want to point out for you, you're probably too modest to admit this, but you were a global director at JP Morgan Chase before this.
Right.
And you decided to, right. And you left. You left because you wanted to do something meaningful for your community.
So I moved from Wall Street to the Main Street. So this is important. And I felt like I'm first-generation immigrant myself. I felt I achieved the American dream, and I got so much help from my colleagues at JP Morgan, and it was my turn to give back. So that's the reason why I retired from Wall Street and then signed up on a whole bunch of nonprofit organizations, and including the hospital board. And I ended up creating my own job. Here I am, working my second career at Holy Name Medical Center, enjoying every minute of it. It's a worthwhile effort.
Let's take a couple questions from the audience, if anyone has any. Because I have a lot more if you don't. Anybody? Right here.
Can you say your name and organization all over for you? Okay. Hi, Amanda Taus here because 3 months out of brain surgery. So thank you to everyone here who worked on mass health, because I wouldn't be alive. Abner, I thought it was really interesting you were talking about lessons learned from other countries. Are there other examples and innovations you've seen deployed in the context of global health and historically underserved populations that you think can continue to aid our Medicaid populations here?
Sure. I think that, in fact, it's funny, I'm going to a conference soon, in part with one of my investors is Acumen America. Acumen is an impact investor, and they're an investor in my company as well. And they've been focused outside of the U.S. for decades, doing really good work in undersourced, poor countries. And they've taken a lot of those lessons and are now applying them in the U.S. So they invested in ConsejoSano because we are addressing low-income people in the U.S. So there is a growing literature and a growing movement even in the U.S. to take examples from other countries that have worked there, particularly for low-income people in low-resource settings, and apply those in the U.S. So it's a growing area. I think there's a lot of opportunity there. I think it makes the point as well that it's why I'm honored to be with these two healthcare leaders. This is unusual to have this kind of diversity in leadership. We've got to do better in the U.S. I'll just want two quick examples. One, when I was starting ConsejoSano that year, there were 89,000 startups. 15 focused on, this is 2015, 15 of the 89,000 focused on Hispanics, one focused on Hispanic health, and that was my company. So some of the smartest people in the country who are building new solutions, they're not focusing on these areas. And then when it came to investment, you can't have a company without capital. It was really hard raising capital for a company that was focused on Medicaid and low-income people. And so I want to give credit where it's due. One of our lead investors is a Massachusetts company, Tufts Health Plan, their venture arm. Tufts Health Ventures invested in ConsejoSano. In 2017, out of all of the venture capital investing that was done in the U.S., 1% went to African Americans and Hispanics. 1%. And 5% went to women. And what I'm saying is, it's not that the point I'm trying to make is that if we're going to have solutions that work, and we're going to have solutions that are targeted to the growing, to the America that we have become and are becoming, we need to do a better job at drawing leadership from those communities. And that's why it's an honor to sit with these two folks. But what you're seeing here is not typical. Do not be fooled by this. This is not typical. We need to do a much better job, and I commend the Atlantic for putting this panel together.
You said something interesting, and I'm going to pose this to you and to Walter, because you're both with for-profit organizations. You said we are a for-profit service, yet we have a social mission. So to both of you, how do you do that?
I don't think that, given the complexity of healthcare today, I honestly don't see that there is that much difference between a nonprofit and a for-profit. We're all struggling in order to provide the best quality of care to our patients in an efficient and affordable way. And so I think that in healthcare, we have to find ways to do things that have high quality, good healthcare outcomes, and have low cost. And whether you are a nonprofit or a for-profit, that remains the same.
What is a small change? Everybody always thinks about these titanic changes. What is a small change that could get us there?
I would suggest that we look really hard at our staffing levels, and that Massachusetts is right now considering some legislation that would require staffing levels. I think that needs to be determined by the hospital administration and not by other institutions or outside agencies. We're able to make the best determination for the quality of care of our patients. And our providers, our doctors, our nurses are very dedicated to the community that we serve. And I think that we're best able to make those determinations within our own institutions and not from the outside. I think that's one of the cost-controlling measures that we have to take a real serious hard look at.
Abner, quickly, I'll let you have the last word.
Sure. In terms of what could...
Social mission, first, social mission and profit.
Yeah, I think that if we keep doing the same thing almost the same way, we're going to get the same results. And that is healthcare to me in America today. We have got to have more innovation, disruption. We've got to do things differently. And innovation is most successful when it's driven by a profit motive. So I think if you look at anywhere, look at whether it's Uber or Netflix, they were talking earlier, anywhere else in our society, innovation is being driven by the private sector. So my view is that innovation is key, and the only way to get that innovation is to have a profit, to have it fast and happen quickly and fail quickly and try new things, is to be for profit and have the profit motive as part of the mission. Not the only part, but it's the part that keeps you honest. It's the part that makes you move fast, and it's the part that makes you not settle for poor results.
Let's thank our panel.